It was popular. And look at it, right?
Okay, ladies, I'm going to ask for your attention because I am recording this, so you'll know that. And know that in this room, unlike my tissue box with my microphone, there are microphones everywhere. So it does pick up. If you want to make this more informal, like we've always wanted to, we can do this as a Q&A, and it all gets picked up. So you know that in advance. But it is recording. Whether or not it works at the end of it, we don't know. But I'm hoping to save it. And so if you're looking at this on our YouTube First Friday list, I'd like to introduce Dr. Margaret Whelan. Dr. Whelan is presenting work that I think is incredibly interesting, Thrown to the Wolves, Later Life, Reconciliations of Former Emergency Room Nurses. Dr. Whelan is a faculty member at Molloy, a professor in all three levels, undergraduate, graduate, and doctoral programs, and has a boatload of experience as a family nurse practitioner. I'm going to turn the microphone over to her, and as I said, I'm going to get the slides up for you, so they're there, and then I'll turn the microphone over to you, and that will be Thrown to the Wolves. You're on. Now the easiest thing to do, let me get rid of this guy. Right here. The easiest thing to do is page down and page up, and then you don't even have to deal with the mouse. But if it doesn't work, you can click in the middle and it works. Dr. Whelan.
Okay, good afternoon, everybody. Nice to be here. This research was my sabbatical research. And as you will probably guess, I'm a former emergency room nurse myself. And over the years, I've noticed that whenever you get together with any other emergency room nurses, everybody is dying to tell their stories. And a lot of people started their careers in the emergency room and then left because of things that happened in the ER. So it was a phenomenological study. And the definition of thrown to the wolves is to put someone who is usually inexperienced into a very difficult and extremely high-pressure situation where there is a high chance of failure. And that's from the UrbanDictionary.com. It's also defined as to cause someone to be in a situation where they are criticized strongly or treated badly and not try to protect them. And that's from the Cambridge Idioms Dictionary. Background. ER nurses have a ringside seat at the tragedies of others. After traumatic events in the ER, nurses were expected to carry on as usual with no time to process or reflect upon what they had just witnessed. Many buried their feelings, resorted to unhealthy coping behaviors, transferred from the ER, or left nursing altogether. The purpose of this study was to determine if former ER nurses experienced adverse emotional or physical effects related to their early years in the ER. There are many quantitative studies of stress in the ER nurse, but no qualitative study investigating the stress of former ER nurses have been found. The effects of stress may not be recognized until midlife and beyond, when resources and protective factors have worn off, and the nurse is more susceptible to stress-related conditions. Why a qualitative study? Since qualitative research offers rich data from an individual's experience, it is hoped that the results of this study will have implications for the health and well-being of other ER nurses. An interpretive phenomenological approach was used to study the world as experienced by an individual to get a deeper understanding of the meaning of the experience and meaning. This Heideggerian approach is based on the historical, socio-political, and cultural context of people's lives. This meaning has universal application not just for the nurses experiencing it, but for other nurses as a shared human phenomenon. The problem. Young nurses were attracted to the drama and excitement of the ER, but were ill-prepared to deal with the consequences. Years later, many former ER nurses can recite from memory the particulars of unforgettable stressful events, mostly related to trauma or premature death. Many continue to blame themselves for negative outcomes. The theoretical framework that I used was the Nurse as Wounded Healer, which was developed by Dr. Marion Conti-O'Hare in 2002. Nurses become wounded healers after recognizing, transforming, and transcending the pain of trauma in their lives. They pass from being the walking wounded to becoming wounded healers, where they can use themselves therapeutically to help others. This will have a positive impact on the nursing profession and on society. There were 9 assumptions of the theory. and I'm going to read each one down the column. All humans experience trauma. Trauma does not resolve without intervention. Therapeutic use of self is dependent on how the trauma has been transformed and transcended. Nurses may have personal or professional trauma or a combination of both. Trauma can be transformed and transcended and used to help others. The wounded healer represents the highest level of using the self therapeutically. How nurses cope with trauma affects patient care. Healing involves transforming from the walking wounded to the wounded healer. Nursing is a wounded profession that must heal itself in order to survive. The walking wounded, an individual who remains physically, emotionally, and spiritually bound to past trauma. This wounding can be reflected in the individual's nursing practice in many ways. The walking wounded have limited consciousness related to just how their pain is manifested in their lives. The wounded healer, through self-reflection and spiritual growth, the individual achieves expanded consciousness through which the trauma is processed, converted, and healed. The Q.U.E.S.T model for self-transcendence can guide individuals in healing. And Q.U.E.S.T stands for question, uncover, experience, search for meaning, transform, and transcend. The Q.U.E.S.T model. Question: how has trauma affected my life? Uncover: what do I remember about the trauma? Experience: what do I feel about these events? Search for meaning: what do these feelings mean for me? Transform and transcend: I change my worldview by resolving trauma and becoming a wounded healer. Review of the literature. The literature on the following topics was reviewed: secondary traumatic stress, compassion fatigue, vicarious traumatization, occupational stress, emergency room nurses, older nurses, and lateral violence. Permission to conduct the study was granted by Molloy's IRB. Informed consent was obtained from each participant. Sample. There were 6 participants, aged 56 to 66, currently living in Colorado, Florida, and New York. Except for one who had worked in an ER in the Southeast, all had worked in ERs in the Northeast. 5 were married, 3 more than once. 1 was widowed. Each had 2 to 3 children, 0 to 7 grandchildren. There were 2 diploma grads, 1 associate's grad, 3 master's grads. Time spent in the ER ranged from 2 to 16 years. 3 were retired from nursing, and 3 were still working in healthcare. Method. 1 participant's interview was conducted over the telephone. All others were done face-to-face. The interviews were guided by open-ended questions. And these were the questions, the interview guide. What was it like working in the ER as a young nurse? Are there any situations from that time that stand out in your mind? Do you think you were prepared for ER nursing? Why did you leave the ER? What would you say to a new nurse considering a career in the ER? Has working in the ER had an impact on your personal or professional life? Themes. Interviews were recorded and transcribed verbatim. Deductive analysis was performed with the emergence of these themes: drama, trauma, unpreparedness, lateral violence, coping, healthy versus unhealthy coping, and outcomes. Drama, and these are verbatim quotations from the interviews. I was so addicted to the adrenaline rush. I worked 11 a.m. to 11 p.m., so I saw all the horribleness of the whole day. The ER is so overwhelming, and it's so traumatic, and it's every system, every age group. I was fascinated by it. I love the fast pace and the variety of patients. When you're an ER nurse, you're a maverick, you're a cowgirl. You work outside the box and you think you're too cool for school. I think it's a place for young people because you have to have that kind of energy and stamina. It's a tough area. The excitement. I love the excitement, but I was insecure. I never felt that confident. You knew you were good because, and this is the sad part, you kept getting pulled into more drama. The better you were, the worse cases you saw. I thought it was the best job I ever had until I didn't think it anymore. It was hard to leave, and I suffered because I missed the action and the excitement and being important to myself. Trauma. I was so young, and I didn't anticipate the trauma I would see. It's not for the faint of heart, let's put it that way. A mentally ill man walked up to a police car and shot and killed the policeman. I had just walked into the ER for my shift, and they wheeled the two of them in. The cop was bleeding and cardiac tamponade. We opened his chest, but he died. The policeman, married for 6 months, died, and the killer lived. A young mother was taking lunch money to her high school-aged daughter. She died in a car accident, and I had to call the family and somehow convey that they needed to get there, and she was already gone. I think the abuse cases were the worst, physical and emotional, and just the hollow look in their eyes. The terrible times when we dropped people on the floor. I saw a baby's face get eaten off by the family dog. The guy who came in with a fractured sinus from a jack which fell off a trailer and came through his windshield like a missile. The mom comes in with the baby all wrapped up, hyperventilating, sunken eyeballs. Mom had been taking him to a nearby clinic. He had diarrhea, but he could have brain damage and die now from dehydration. She was sobbing on me, and I felt so upset that she had probably struggled to get to this country and work, only to have her toddler die here. It's missing the top here. The elderly woman, I remember, who was raped by a food delivery guy. He pushed his way into her apartment and raped her, and I was absolutely horrified. I had no idea. Like, who does this? We had a woman who fell asleep smoking in bed and had third-degree burns all over her body. The smell of that made me faint. The smell of burnt flesh stayed in my nose for days. We had an older child who was sick all his life and should have aged out of pediatrics, but he was still in pediatrics, and it was a horrible code, and he died. And the doctor who was so attached to him was just heartbroken. It was just really horrible to see a kid go. Unpreparedness. When you come out of school, you're book smart, but you don't know what the real world is out there. You cannot emotionally comprehend someone who comes in with a bullet wound, or a child having seizures, or a child who is dying. I didn't realize I was missing out on the training. I didn't even notice that we had no in-service. It is very hard to do holistic care when they are pushing you to get the patient out and get them discharged and leave the bed. I've always had anxiety, even before I was an ER nurse. I was young, and I didn't anticipate the trauma I would see. There's just so many people, and you see so much drama and trauma and everything. I was definitely not prepared for the emotional aspects of working in the ER. I don't remember ever taking an ER course. There was never any debriefing or case conferences or in-services or preparation, nothing. Nothing was ever really acknowledged as good or bad. I never felt appreciated there at all. I mean, you did what you had to do. I learned that. I always did what I had to do. Go on to the next patient. You just went on. We were thrown to the wolves. That's where the study comes from. Okay, lateral violence in the workplace may be verbal, gossiping, persistent criticism, berating or belittling, or nonverbal, assigning unmanageable workloads, sabotaging, clique formation, failure to respect privacy or keep confidences. It creates a toxic work environment and results in psychological distress for the person experiencing it. And this is the theme of lateral violence. They had some really tough nurses. When you're in the ER in the city, you stand out if you're one of those nicey nice nurses. We had some bitches there. The hardness is the culture, and I became that too. I hated that I became that way, but that's survival mode, and it's horrible. There were times when you felt so dumped on, and so what did you do with all that anger and resentment? But there was real snobbery there. I felt it. When I got my evaluation from the head nurse, whom I emulated, it was not positive, and my supervisor told me that the head nurse was jealous of the attention I got from the doctors. That was hurtful and shocking. I don't like conflict, believe it or not. The ER is full of conflict. I am not a lover of fights or all that intensity and anger. We had some nurses who were mean as snakes, and this one princess who was all about makeup, and she was nauseating. Okay, these are some healthy coping behaviors that came, out of the interviews. Being a person of faith, it just helped me, and that transferred to the care I gave people. I guess I turned it all over to God. I read When Bad Things Happen to Good People by a rabbi. Those self-help books helped me a lot. I discussed things with my friends, and I would travel a lot and get out of the city in the summer. It was just so hot and brutal. It was a fast life. Within 2 years, I had my certification in ER nursing and did trauma training in the city. I knew if I were going to work there, I had to be the best. I had to get the best training I could. I didn't want to let down the mentors who recruited me. I can see how spirituality helps people, but I've never been a religious person. I never had that comfort. Some people do, and I recognize that. I was very involved in the church. There were nurses in my Sunday school class, and we were in a garden and social club, but we didn't talk shop when we went out. We were smart alecks to relieve stress. It's self-protective, but it's mean. The laughing, making fun of people. If you didn't laugh, what the heck would you do? We would make a pot of coffee at midnight, and everyone would call their spouses and say, "I'll be there when I get there." We would discuss things and start from anger, like that respiratory therapist is an asshole, and then we'd end up laughing. Some unhealthy coping behavior. And maybe some of those coping behaviors, what I considered healthy, maybe you consider them unhealthy, but sometimes you have to laugh, sometimes you have to be a smart aleck. Unhealthy coping. Drinking definitely was something I used to calm down at the end of a shift. So I was always very busy, so I didn't have a lot of time to think about my traumas. At Al-Anon, they say, busier is better. A lot of drinking, a lot of smoking, a lot of affairs. Quick fixes to escape reality. A lot of bad marriages, especially first marriages. They all married guys who were not great for them. My first husband was not fixable either. I was a real party girl, and I led a risky life myself, always on the edge. There was a lot of anger and resentment and humor and all those unhealthy things. Drinking. I'm a recovering alcoholic, so I drank a lot. My old friend Jake was wonderful. He was a bully to patients, and he kind of made you feel safe because he wasn't afraid to do or say anything. I had relationships with doctors and long-term affairs. It was part of my being. It was an escape. It was a stress reducer. It was getting outside of the reality. The nurses would talk in the back room, and one time we were talking about alcoholism, and 9 out of 10 of us were children of alcoholics. So we were enabling, not getting angry, the past anger directed at patients because you cannot separate your own emotions. The ER attracted the tough, edgy, or the sad, or the black and white thinkers. Too much detachment, and I'm sure they brought it home to their families. Outcomes. I could not get that car accident out of my head. The crushed car, and she's talking about her daughter here who was in this car accident. Her flat on the ground, all that stuff that would trigger all my other things that I've seen in my life, all the traumas and the terrible things. A lot of my old ER friends have autoimmune stuff and are in poor health. One of them passed away. I have palpitations. If I watch a scary TV show, I get palpitations. I am hypervigilant with my grandkids because you know everything that can go on. A paper clip is a potential life threatener. Before, I was a little stupider, a little more relaxed. I envy people like that. When I left the ER, I immediately gave up smoking and got a better job with much less stress. I started living a balanced life with the goal of getting healthier. Sometimes I would go that way with my family and be overprotective, but not in a good way. As much as you like them to go out and do things, you would probably like to wrap them in bubble wrap. Talking about her family. I didn't take the kids in the car to the airport to pick up my husband because what if someone hits us? It's amazing that your critical thinking skills get so good in terms of just sifting through all kinds of problems and issues, and your triage thinking really comes in handy in life. It absolutely has an effect on family. My kids used to tease me that you had to have your arm hanging off before you got any attention from mom because you get sensitized to pain in people and what they're struggling with. Then, of course, I went through the process of maybe I should have seen him sooner, or maybe I could have done this or done that. I think I did pretty much everything I could, but I think we all go through that, the terrible should have, could have, would have stuff. more outcomes. I have palpitations and I'm on a beta blocker. Most of us in the ER converted to a positive BPD. 3 bad discs in my back, that came with the territory. There was a lot of heavy lifting. I don't think I prayed then as much as I do now. I think that the world is an unsafe place. When my daughter started driving, I knew I had absolutely no control, and I could make myself sick over it. I wouldn't let my son play football. Every time they went to a party, I stressed knowing how deep the pool was before they dove in. Knowing what I know, I worry about things more than the average person. On some level, my family appreciates my hypervigilance because there's no stone unturned, and that probably once saved my husband's life. She had been talking about when he was hospitalized and, in a very prestigious hospital, but they didn't pick up on some of the things that were going on, and because she was hypervigilant, she was able to pick it up. I don't think it was necessary at age 19 to be exposed to the traumatic emotional aspects. I think the experience was invaluable, but I don't think people at a young age need to be exposed to that reality. You could be sitting with everyone having a good time when you become a lunatic because the child is near a picket fence, or if the parents are not watching the baby with a screwdriver who could poke his eyes out, and it becomes impossible to have a good time. It does affect your worldview. You know how quickly someone could pass away, which regular people don't. I think that some knowledge can be a burden later on, causing you to become a little more fearful or cautious or worried later on. My kids call me Hazard Harry. I almost had a full-blown panic attack thinking of my grandkids on a Disney cruise, and I pictured them running off the gangplank before we even got on. Okay, conclusions and implications. Former ER nurses reported being ill-prepared to work in the ER and greatly affected by their early experiences. However, some stated that the ER prepared them well for other nursing positions. Nurses, especially neophytes, must be educated and prepared for this type of physically and emotionally challenging work. Ongoing support must be offered to them to prevent untoward long-term consequences. With gratitude, I would like to thank the 6 nurses who participated in my study for their honesty and willingness to relive their ER experiences. To quote one of those former ER nurses, "Those questions are very good. They conjure up a very interesting memory of a job that I'm so glad I don't do anymore." So does anybody have any questions? Can anybody relate?
Wow.
Well, let me ask you, do you think it's just ER nurses?
No. I'm certain it would be relevant to nurses who work in intensive care units.
Oh, absolutely.
I mean, ED is a intensive care unit.
I actually presented this research at a qualitative conference. It wasn't just nursing, it was all disciplines. And the people in the room who listened to the presentation, the ones who identified most with it were teachers, elementary school teachers. It was a national conference, so they would come all over. And,
If people could see what I know, because I've seen it all. I think that's the message. If others knew what I know, then I know that you could die, or you could fail, or these things can happen.
So, Peg, do you think it's only ED nurses? I mean, some of those outcomes, like, being hypervigilant or worrying, I mean, I could relate to that as a parent, without also being a nurse, that whole.
But it's probably because of, you have a different perspective and people see you differently because you're the nurse.
I don't know.
I mean,
you know
the
what?
nursing
I don't know.
background has to have an effect on it.
I know, but I mean, I can also think about people that I know who are not nurses.
Who feel the same way.
Yeah.
But you have a more concentrated experience as a nurse and seeing so many different scenarios, if you will, and so many different outcomes, and also know the background of what's going on. And I would venture to say it's not just ED nurses, not just ICU nurses. It's really, it depends on where you're working, but
Right.
your experiences, even in med-surg,
Sure.
pediatrics, etc.
Sure.
I'm interested in knowing how you felt in interviewing the emergency department nurses.
It's funny you
being the
asked that,
former one.
because yesterday a doctoral student had been assigned as part of her qualitative research course to interview a researcher about how the researcher felt when doing qualitative research. How did I feel? It didn't upset me as much as it validated what I've been feeling for the past 40-something years. It was very gratifying to me because I could tell that the participants were so relieved to tell their story. In fact, the way I got participants is I would interview somebody and they would say, oh, you have to talk to my sister, or oh, you have to talk to so-and-so, because they've been trying to find an outlet for their feelings for a long time. So I actually didn't relive my own experiences listening to this because I relived them anyhow. This was not a factor. I do relive them. And this one nurse said her family calls her Hazard Harry. My family calls me Safety Joe because I always have to think of, I can't just enjoy, especially with the grandchildren. I think with my own kids, I was so busy at the time working, going to school, but now I have a little bit more time to worry a lot about things. So, I was glad to do it because it really seemed to help the people who were talking about it. And they wanted to keep talking about it.
So what would you suggest in terms of helping people? I mean, I think nurses kind of automatically do that for each other. You all go out, you all sit in the back, you're telling war stories. I mean, I think we started it when we were in school.
Mm-hmm.
I mean, I remember staying up for hours in the dorm and we would talk about our experiences were not nearly as traumatic as working in an ED because we were still students. So I think people, kind of do that anyway. So, I mean, have you thought about how to
Well, I think you need preparation before you even go into it. I mean, in my own case, I was hired straight after graduation.
Right.
I mean, I was just pulled right in there, Bellevue's ER. And it was, I was young. I thought I was cool shot. I thought I was too cool for school. Oh, I can do this. And I did. You do it. Just like, who do we send to war? The young people. The 18-year-olds when you're young but later on, it does hit you. It hits you. And I still remember, and different little things hit you. Like, I still remember a woman who was shopping at Macy's, and she came out and she had all her Christmas shopping bags, and they contained all toys and stuff for her grandchildren. And she was hit by a bus. So she came in, she was on the stretcher, and underneath the stretcher were all her packages from her Christmas presents from Macy's. And that little, when you see the humanity, if it's just a body on a stretcher that you have to do this. But when seeing the Christmas presents, I had to leave. I said, I have to take a moment. There were other people there. Just things like that. Or you remember vividly every time somebody came bursting through the ER doors holding a baby wrapped in a blanket, and that's going to be a 6. So just different things will trigger. I think all parents, worry, but I think nurses worry more than most, especially the ER nurses, because the unpredictability of, and that was it, who's going to burst through the door? What's the enemy going to burst through the door with? Am I prepared? And you weren't prepared, other than not having a lot of fear because you were young and you were, you haven't experienced much of the world. And also in working in Bellevue's ER, I know it was very anonymous, but once I moved out to Long Island and I worked in the ER in my town, I had a really tough time because I thought anybody bursting through the door was going to be somebody I knew. My father having a heart attack, somebody having a car accident, living in a beach community, so many fractured cervical spines, near drownings, So it's not for the faint of heart. That's for sure.
I know a lot of police officers and first responders who are the front line and see trauma and observe trauma who know of one guy in particular who had a triggering event that said, I can't do this anymore. Not to be able to leave the room, but quit. And left his gun in his room with a note that said, I can't do this anymore, and drove away. Did any of your guys have any pivotal event, single event, anything that was too much to do and quit?
That didn't come out in the interview. I didn't specifically ask them what caused them to leave. I think just by virtue of hearing what they had experienced, they decided at one point to get out of there.
Part of it's just I see some of our colleagues come back after 8 hours with their supervising students exhausted, and I think part of it's being tired, and tired is, on your feet for 8 hours. That ultimately some people might decide they want a different kind of easier job. I think I'll go teach. I'll go teach, right? I'll go teach.
I think it was the Emergency Nurses Association that fairly recently put out a white paper on fatigue in ER nurses, and they did another one on substance abuse in ER nurses. So,
and I'm going to ask you something that you probably didn't have in the front end, but you might have seen. I know there are studies, but I can't quote them, that there's certain personality types of people that go into certain areas.
oh yeah,
So,
people who want to fix it. 9 out of 10 of them in this one group were children of alcoholics.
yeah.
Yeah.
I wanted to make a comment too, is that it's interesting how they said, because they're looking back retrospectively, it's more for a young person to do this kind of work. But then we think of people who actually, like yourself, who were thrown into it at a very young age, when you're not maybe yet emotionally mature, have those experiences. So it's almost like a double-sword edge. You want to be young, but at the same time, maybe being young is not the best time to be there.
Right. Or if you're young, be prepared. Have some, I don't know, do they have ER preparation classes in the hospitals?
Well, absolutely.
Oh, that's that. We have an expert here.
And I was going to ask you a question as well. Yes, we have an ED fellowship program. So we prepare nurses who have worked at least a year in med-surg. That's emergency department when you graduate.
No idea. I think somebody's just joined us, so we'll just keep talking. You'll
Okay.
be hearing us talk.
So, so after a year of working med-surg, they do come into our emergency department and spend 1 full year in the fellowship, getting trained, being supervised or at least supported by an emergency department educator, and getting a full experience of the emergency department in all different areas. And we felt that has helped greatly. The feedback that we've gotten, they felt much more prepared.
Well, it's probably good that you have an educator, not just the ER nurses themselves, because they tend to be a group that maybe would discourage somebody from there. You know what I mean? They get a little jaded after a while, I think.
Did you lose a lot of people out of that program, or?
Nope, they stayed. They did very well. They stayed in the emergency department. Some of them moved on to other positions in the emergency department other than staff nurses. So it's been very good. Not a large class. It runs between 6 and 10 people per year.
Other institutions as well. I think one of the things that I'm thinking about, like, these are people who are a bit older, and I think we can certainly attest to the fact that when we started nursing, you just started. My first job was in a recovery room. My orientation was, here's a fire manual, this is how you get paid, welcome to work.
Right.
Apart from, well, they were not doing it all.
Here's the keys. Here's the
Yeah, exactly.
The hard side,
Right.
the regular side.
Right.
So
Yeah,
I
first
would,
job.
not to say that that is all not still relevant, but I think that we've recognized that there's much more to caring for patients safely than just only going to school, that there's these other things in place. There are fellowships, I think.
And debriefing after.
And support. I mean,
Debriefing after critical
absolutely,
events.
right? I'm sure
And
you must have
validating the
somebody.
feeling.
Right.
Yeah.
With that, debriefing, validating, gee, I'm not the only one feeling this. Very.
I don't think those are formalized. And they might ought to be. I know some people were innovative, and if you were going to take this anywhere, if you wanted to formalize something, that you called, posted a sign to say, I'm going to have a little chat session, cup of coffee, come and talk. I think that would be invaluable for an institution. If they've been formalizing it, making every Monday at 2 o'clock, I don't know that that's necessarily a good idea, but putting it in the structure of opportunity for people to do to that. I think that'd be a really good idea.
Gloria, I'm going to take your question in a minute, but my idea for another study was to look at nurses who stayed in the ER. And there are nurses who are in their 50s and 60s who still work in the ER, who never left an ER setting. What makes them stay? You know, that would be interesting to hear from them. And I was talking about it last night, and Maureen Mulder said, oh, I'd like to do that too. I actually got all my articles out, and I'm going to give her copies, and we're going to look at it.
Good.
So, and what did you want to
Yeah, I was thinking that, for example, the nurses that stayed, my thoughts are that there are some people, like Dr. Schechter was saying earlier, some people don't have to be nurses, or there are just some people who are prone to anxiety. Is that the right thing to say? There's some people are just nervous people. That's how they are. That's how they were born. Exactly.
Yeah,
the different temperaments we have. So I just wanted to know whether, I know you didn't mention it, but maybe it didn't happen. Maybe that wasn't the way you went. But maybe if we try to find out the people's temperaments before, they even do the interview. Because maybe there could be those people, that's how they are already. Because there are some people who don't want their children to even climb this chair because they're going to break a tooth or they're going to break their leg or something. Some people are just like that. And they stay-home moms. That's how they are. So I was just thinking about such people. And also the people who stayed and never left probably are the stronger people who, in everyday life can deal with things like that.
Or love an adrenaline rush.
Right, and that's how they
love
are.
an adrenaline rush to me
That's-
is a
yes,
characteristic
that's how
of
they
my
are.
colleagues that stayed
Right.
and worked. They were the ones that loved every minute of it.
Right. And another thing is, I've always been thinking about ER nurses, and when you were speaking, I was thinking about OB nurses too.
Right.
It's just like an emergency room. You don't never know who is coming through the doors.
That's right.
And for those of us who worked in other countries before coming here, we've seen some real stuff go on. And the thing is, I have been thinking about ER nurses, and I'm thinking, is it possible to have like a rotation where somebody doesn't have to stay in the ER for 12 years if they don't want to? Because once they get a job in a hospital, let's say for example, my hospital, we have 1199, the union is good, and people getting through the ER. Most of the time they need ER nurses. So I appreciate the fellowship that they have there in your hospital and other hospitals. I don't think we have it in my hospital. But they need a job. They get into the hospital through the ER, and they get stuck in the ER. They can't move anywhere.
Why?
Because maybe they apply for upstairs, they can't go, but they don't want to leave the job because they have all these benefits that they don't want to lose. So it gets to a point where they become, burn out of nurses. They're really not effective there, but they're there. And if you ask Farakaway community, they'll tell you that the ER is the worst place. Not because the nurses don't do a good job, but I think some have been there and they really want out, but they can't get out. So I've been thinking about if there could be like a rotation where you could, if you do a maximum of a year or two, and you want to move, relocate in the hospital, there has to be a way for you to be able to do that. And I think that's gonna.
I think in any hospital they should be allowed. If they really don't like where they're working, or you no longer feel like you're being effective, you should be allowed to make the transfer.
But if there's no opening anywhere, you might have to get out of the hospital.
It's probably very expensive to orient somebody to the ER and just think that they're only going to stay for a year.
And it's all very contingent on the job market, because that's one of the things that from our work of where people get hired to is where they need people, and that's where they're going to be. And being stuck is a perception if that's where you can't go any place from it. But what I think Lori is saying, we were talking about last night, that we acknowledge these are very skilled, very special, very knowledgeable nurses. And when they even want some sort of respite or break, there's no flexibility in a 2-day week or a changing week and that sort of thing. Or when they get older and want to not completely retire, but to cut back on hours. We still live in systems that don't allow that sort of thing. And it's a shame to lose the town, is what we were saying last night. So, and you've had, people yourself that couldn't go to a 3-day week as a part-time person.
I mean, I think we have to need
Or job sharing.
adaptations for older nurses, and that's a whole other
Yeah.
topic, but I think if we want to keep these older nurses, and I mean, they have an incredible amount of wisdom. I mean, maybe physically they can't stay on their feet as long or, do the heavy lifting, but the wisdom. In fact, at this national conference, qualitative conference, somebody that was there, she actually was in nursing, and she said, "Oh, you're talking about the gray gorillas." And I'm like, "The gray gorillas?" And she said, "Yeah, that's a term for nurses who've been, in a certain area for a long time, and they get very protective over their patients and their staff, and they protect them against the doctors." And so I, of course, went and looked at gray gorillas. I think there was only maybe 1 or 2 articles on the gray gorillas who are strong and have wisdom and are protective, but sometimes they are obstructionists as well, in terms of, making changes in a unit. So just,
What's your most important takeaway on this?
I guess for me, the most important takeaway was that, we have to recognize that what people do when they're young, if they're not supported properly and not given recognition, they're going to feel it later on. It could affect them in a very strong way going forward. And I think we have to support our ER nurses. I think before we put them in the ER, we've got to do something for them, support them while they're there, and, have some sort of professional interventions with them. Because I know at Memorial Sloan Kettering, they do have people, either psychiatric nurse practitioners or psychologists, who do have regular meetings with the nursing staff because of the traumas that they go through. And something like that wouldn't be a bad idea. Sounds really good.
Anybody else? Thank you, Peg, for coming and making us here and sit you down, and thank you, everyone.
I have some copies of my poster.
Oh, you still collecting?